New developments. The Thomas splint. This was basically a splint that helped fractured bones to heal. At the beginning of the war, soldiers who had broken their femur, their thigh bone, from gunfire died in huge numbers. It is estimated that 80% of soldiers shot in this way died between 14 and 1915. This is because doctors only had very simple splints which did not stop the broken ends of the bones, causing significant blood loss. The Thomas splint was invented by Hugh Owen Thomas, who was a surgeon from Liverpool. His splint pulled the leg lengthways and stopped the bones grinding on each other, which caused new blood loss. By chance, Thomas's nephew, Robert Jones, became the Army's Director of Military Orthopaedics in 1916 and made sure that the Thomas splint was used. Regimental medical officers were now taught how to use the splint, and it was used in aid-person dressing stations. By the time soldiers reached the casualty clearing stations, they were fit enough to be operated on. The Thomas splint reduced the death rate from 80% to 20%. Mobile X-ray machines. Many casualties in World War I were injured by bullets or shrapnel. These injuries needed to be located quickly to make surgery quicker and more successful. X-rays made rapid location of the injuries possible and helped surgeons remove shrapnel more easily and more quickly. Increased use of X-rays reduced the death rate considerably. However, the use of X-rays was not as effective at the beginning of the war as it was by the end. In January 1915, there were only 2 mobile X-ray vehicles in the British Army. However, by 1916, most casualty clearing stations and hospitals had X-ray equipment, and X-ray lorries were usually attached to casualty clearing stations. Blood transfusions and storage. Karl Landsteiner had shown that blood could be transfused from one person to another successfully by identifying blood groups. However, the problem of how to store blood and stop it from clotting still existed. The huge wartime need for blood made solving this problem very urgent. High explosives and machine guns led to many men dying from blood loss. The problem began to be solved when an American scientist called Richard Lewison discovered that sodium citrate could stop the blood from clotting. This meant blood could be stored, although the blood quickly deteriorated. Next, scientists found that blood could be stored in refrigerated conditions and that adding citrate glucose allowed it to be stored for several days after being collected. Next, a British surgeon called Geoffrey Keynes created a portable machine that could be used to take blood closer to the front lines. Soldiers could now receive blood sooner, and this stopped their bodies going into shock. The first blood depot was created at the Battle of Cambrai in 1917. Blood group O, which could be given to anyone, was collected and held in readiness for the battle. Brain surgery. Head injuries were another injury suffered by soldiers. As soldiers stood in the trenches, their heads were their most vulnerable place. Before 1914, little surgery had been carried out on the brain. So in 1914, little surgery was done on the brain and wounds were instead bandaged. Also, brain surgery would take a lot of time, and doctors felt that their time could be better served helping other casualties. However, the number of head injuries made doctors to try new ideas. One simple idea was putting rubber bands around the head to put pressure on wounds and reduce bleeding. More soldiers were kept alive and fit enough to cope with operations because of blood transfusions. Also, surgeons developed new techniques. The use of X-rays meant that surgeons could more easily locate and remove bullet fragments from the skull. The surgeon Harvey Cushing also invented a surgical magnet to remove bullet fragments from the skull. Treating wounds and infection. A solution to wound infection was developed by Alexis Carroll and Henry Dakin. They developed a system of tubes, the Carroll-Dakin method, which kept a chemical solution flowing through the wound and fought infection or stopped it developing. This was effective because it was continuous and reduced the number of amputations because of infection. The second major development was to carry out deeper surgery and cut away more tissue around the wound. In 1914, surgeons would simply remove the bullet and sew up the wound, but by 1915, surgeons made sure all shell and bullet fragments were removed. They also made sure all tissue and dead muscle surrounding the wound was removed. Wounds were also kept open so that antiseptics could be used. The chance of getting infections like tetanus and gas gangrene were now reduced. Plastic surgery. During World War I, surgeons carried out over 11,000 plastic surgery operations and learned from each other and trial and error. By November 1915, there were 7 hospitals in France that specialized in plastic surgery. Surgeons developed new techniques like using jaw splints and wiring and metal plates as replacement cheeks. Harold Gillis was a New Zealand plastic surgeon who served in the RMAC In France, he worked with French surgeons and learned from their techniques. He also used a technique called pedicle tubes to grow new skin to facial injuries. He persuaded the Army's chief surgeon to open a hospital for facial injury and care.